Good morning. Thank you for the invitation. On behalf of the AGA, I really would like to say we are very happy for this collaboration that we are having with the Mexican Association of Gastroenterology. And to Dr. Remes and the other board of directors, we very much appreciate the invitation to participate in our collaboration. In choosing studies from the DDW this year, I tried to identify things that I feel have potential to impact our practice of gastroenterology clinically. I've chosen things from various sections of the gastroenterology of the GI tract, and we'll start with esophageal diseases and a study that challenges the issue of screening for Barrett's esophagus. And so this study, called the BOSS study, is designed to assess the benefits of surveillance as we typically do it versus as needed endoscopy, meaning patients who will receive an endoscopy based on symptoms. 3,400 patients with at least 1 centimeter of Barrett's esophagus were randomly assigned to either surveillance endoscopy or as needed endoscopy when their symptoms arose. Both groups were followed for 10 years. The interesting thing is that those who were in the Barrett's arm, they had a mean of 3.5 endoscopies over 10 years versus 1.4 for those in the at-need arm. With respect to the primary study endpoint, despite the Barrett's esophagus surveillance group having twice the number of endoscopies, there was no difference between surveillance and the at-need groups with respect to all-cause mortality or cancer-specific mortality. So the significance of the study is that this is the largest and the longest randomized trial evaluating whether surveillance EGD reduces the risk for death in patients with Barrett's esophagus. And then this study didn't find any difference in all-cause or cancer-specific mortality, which challenges our current paradigm with respect to offering surveillance. And so clearly this is at the end of this issue, but it stimulates an interesting discussion, which I'm sure we will be hearing more about. An interesting observation that I noted with respect to a study in GI bleeding is the following. This was a study that looked at the prokinetics agents which we use to clear the stomach prior to endoscopy in patients who are having GI bleeding. And it was a systematic analysis that looked at 7 interventions: azithromycin, erythromycin, plus or minus an NG tube, metoclopramide, plus or minus the NG tube, or an NG tube or placebo alone. A very interesting observation is if you look on the far right column at the various cases, surprisingly, at least for me, azithromycin was associated with a highest odd ratio, much, much higher than the ones which we currently use, which is erythromycin. And so it leads to the idea that with respect to having the stomach clear of blood prior to endoscopy, azithromycin shows promise as a superior alternative to erythromycin. Another study in GI bleeding comes from Harvard, where they look at this point-of-care blood detection capsule and as it relates to making decisions about how to triage patients who present with GI bleeding. So the new point-of-care blood detection capsule is a single-use ingestible capsule equipped with an optical sensor that detects blood by analyzing light absorption. It has a companion reusable handheld device which wirelessly receives the data from the ingested capsule, and it displays on its display either blood detected or blood not detected. It is approved by the Food and Drug Administration in the United States for the detection of blood in the upper GI tract. So the way that this procedure proceeds is, one, there's pairing of the capsule with the device. The subjects then swallow the capsule and then stay in the recumbent position for at least 10 minutes, and then the device that indicates either blood or no blood is detected. So the method of the study that was done was a multi-center between Brigham and Women's and Harvard, a retrospective study which prospectively collected the data at these two centers. Inclusion criteria were patients with clinical suspicions for upper GI bleeding who underwent evaluation with this blood detection capsule, and exclusion criteria being evidence of obstruction, a motility disorder, dysphagia, pregnancy, or an implanted electromedical device. Using endoscopy, upper GI endoscopy as the gold standard, the patients who had positive capsule study, most of those patients had a positive EGD. On the other side, most patients with a negative capsule had a negative EGD in terms rendering the following performance characteristics. So this capsule, with respect to its ability to detect recent or active upper GI bleeding, has a sensitivity of 87% and a specificity of 90% with excellent positive likelihood ratio and negative likelihood ratios as well. So this leads to the conclusion that this is a safe and effective tool for detecting upper GI bleeding at the point of care. It's not replacing endoscopy, but it's being used to help triage patients. So it optimizes resource utilization. I heard from the presenters in the previous session that resource utilization with endoscopy is an issue in Mexico. It avoided this capsule avoided upper endoscopies in 35% of the cases, many of whom were discharged from the emergency department. No adverse events, and this real-world utility supports integration of this capsule into routine practice, and it may alleviate healthcare burdens and improve patient outcomes. With respect to pancreatic disease, a very interesting animal study looking at intraductal papillary mucinous neoplasms, the IPMNs. So this was a mouse study that addresses the following issue. The big issue with us in surveying and treating IPMNs, as you well know, is the need for pancreatectomy or partial pancreatectomy. Well, these investigators have developed a chemical pancreatectomy using intraductal infusion of 1 to 2% acetic acid, which leads to the ablation of the pancreas acini and the ducts while preserving islet cell function. Their hypothesis was that if they could do chemical pancreatectomy to ablate the ductal cells, this could prevent IPMN development and recurrence and progression and recurrence in patients at risk. So they used this hypothesis to generate the following. They inserted in a mice model, genetic mutations were delivered by adenovirus vectors into the pancreatic ducts to produce the IPMNs. And then the chemical pancreatectomy was achieved by injection of the acetic acid into the pancreatic duct. Their observations is they were able to generate these mice who had IPMNs, as you can see, either described by the blue arrows in radiographic imaging or in the gross appearance of the pancreatic cyst. And then the most important observation from the study is that chemical pancreatectomy, when looking at total tumor volume in IPMNs compared to normal saline control, dramatically reduced the volume, the total volume of IPMNs in the mouse model. And using glucose tolerance testing as a measure of endocrine function of the pancreas in the rats who had undergone chemical pancreatectomy, they maintained the endocrine function of their pancreas. So leading to the conclusions that this inducible model in mice of IPMNs by infusing an adenovirus vector to deliver genetic mutations so that they would have IPMN models that demonstrated that chemical pancreatectomy successfully prevents the IPMN, and that chemical pancreatectomy could be translated into clinical trials in the future. Also, in the realm of pancreatic diseases, a very interesting study looking at therapy for IgG4 diseases of the pancreas and the biliary tract. The background is that nabizolab, which has been studied already in a trial called the Mitigate trial, was a phase 3 trial looking at this agent as a treatment for IgG4 disease of the pancreas, biliary tract, as well as other organs. The current study looked at the subgroup analysis of the overall trial for the efficacy of inelbizumab, which is an anti-CD19 antibody for the treatment of IgG4 disease, specific for those who have diseases of the pancreas and or bile duct. What they observed was, in my opinion, amazing. When looking at specifically the pancreas or bile duct or people who have pancreatic and biliary disease, there was a dramatic reduction in the incidence of flares with this agent, with amazing hazard ratios and highly statistically significant. Also, when assessing flare-free, glucocorticoid-free remission, similarly, for those who have pancreas and bile duct disease, was amazing odds ratio for the ability of this agent to treat those with IgG4, pancreatic, and biliary disease. So this trial's significance is that it confirms the benefits of inelbizumab in patients who have IgG4-related disease, that's specific to the pancreas and the bile ducts. And the results of this trial offer a highly efficacious treatment option for these patients in whom we haven't had multiple treatments other than corticosteroids or rituximab previously. Moving to inflammatory bowel diseases, there was an interesting trial called the ADAPT trial that looked at the efficacy of a low-dose emulsifier diet in patients with mild to moderately active Crohn's disease. And so when I saw this, I thought it'd be helpful to review what an emulsifier is. So emulsifiers are food additives that help stabilize mixtures of ingredients that don't normally mix well, like oil and water. So for example, on the right is a picture of a mayonnaise without the emulsifier. So the emulsifier's presence helps keep everything in suspension. Examples of this clinically are things like peanut butter and ice cream and cake icings and some frozen desserts. Also, lecithin, some soy, sunflower, and egg are examples of emulsifiers. So here's what they did in the ADAPT trial. It was a multi-center randomized double-blind placebo-controlled trial. It took 154 patients with mild to moderately active Crohn's disease, took half of the patients and put them on a low emulsifier diet for 8 weeks, compared against a control group of patients who had a diet containing emulsifier foods, also treated for 8 weeks. With respect to results, they observed the low emulsifier diet significantly improved clinical outcomes compared to the control. Patients on the low emulsifier diet were 3 times more likely to improve their clinical disease and twice as likely to achieve remission. And so this study suggests that food additives, particularly the emulsifiers, contribute to gut inflammation and symptom burden in patients who have Crohn's disease, with the implication that this study provides very, very strong evidence that dietary emulsifiers play a role in Crohn's disease, and it supports clinically that dietary modification with low emulsifier diet alongside standard medical therapy for Crohn's disease is something that may be considered in our clinical practices. Moving to the colon, I thought that it would be helpful to have a review of where we are in our use of artificial intelligence for the detection of colon polyps. Well, past studies that have looked at computer-aided detection systems in colon polyp detection have generally shown the following. They've shown small, and when I say small, usually 1 or 2%, but statistically significant differences in improvements of adenoma detection rates in those studies where AI has been used. However, most of the polyps that are identified by the computer-assisted detection models were small and often of questionable clinical significance because typically the 1 to 2% difference between the two study arms. Furthermore, when the clinical trials have been taken to real-world clinical practice, any benefit previously seen from the clinical trials have not been seen in real-world studies of colonoscopy using computer-aided detection. And then finally, the issue with these past studies is that where we have the biggest challenges in colonoscopy are for flat lesions and for sessile serrated adenomas. And in the previous studies, there have not been many sessile serrated adenomas or advanced lesions that were included in those trials. And then also the previous trials with respect to cancer outcomes, those outcomes have not yet been proven. So this leads us to the trial that caught my attention from DDW, which uses cloud-based artificial intelligence for detection of colorectal neoplasms, and it was a randomized controlled trial. So the benefit of a cloud-based system that's connected to our colonoscopes is that the real benefit of AI is the machine learning. And when you have a system that is real time attached to the cloud, it's always continuing to learn. It's always continuing to update its applications with existing AI applications or integrating new AI applications. So within the context of a day, the machine is smarter today than it was yesterday. And so using the real-time computer-assisted trial, this led to the EAGLE trial, which was a multi-center randomized control trial from Europe using 8 different sites, importantly incorporating experienced endoscopists. So all of the endoscopists had an adenoma detection rate of at least 25%. And in the trial, they assessed polyp detection using this cloud-based computer-assisted detection systems versus standard colonoscopy. This AI training data included a high proportion of sessile serrated lesions, and that's really important, as well as large polyps, which allowed increased use of the sessile serrated lesions during colonoscopy. What they observed was really much better than previous trials. So its performance of using this cloud-based system, as opposed to a 1 to 2% difference compared to standard colonoscopy, you can see the differences with respect to adenoma detection rate, polyp detection rate, mean detection of the sessile serrated lesions, as well as the ability to detect lesions that are greater than 10 millimeters, whether they just be all polyps or adenomatous polyps, all at statistically significant values. So the implications of this EAGLE trial are the following. Use of a cloud-based system with very rapid processing, having the lesions processed in less than 100 milliseconds, has led to, and using this system, which it has machine learning that allows itself to be constantly trained on new data sets, allows us to identify an abundance of large flat polyps. This appears to translate into improved detection for both large flat adenomas, as well as sessile serrated adenomas. With that, I think that's the last trial that I wanted to review for you today. Thank you very much for your attention.